Hi, very good morning. Today I'm going to talk. I'm Dr. Janak Patel. Today I'm going to talk on how you examine rhythm in ECG strip. So rhythm can be examined by examining pulse as well as by examining ECG strip. But in pulse, you can examine only rate and you can examine regularity, but you cannot identify the origin of the pacemaker, which you can do only by examining ECG strip. Again repeating, you can see only what you look for, you will recognize only what you know, and you will remember what you understand. So I'll try to make it as simple as possible so that you can understand very nicely and you can remember for lifetime. So we'll be starting with a topic we call as a ECG rhythm. Again, see as much ECG as possible and listen to the person who is explaining you as much as possible, and then you will know more and more. So we start with a rhythm. So rhythm means two ways. One, rate. Second, regularity. And third, origin of the pacemaker. As far as pulse is concerned, you can calculate the rate. Whether it is between 60 to 100, we call that as a normal. Whether it is irregular, regular, whatever it is, but we call that as normal. When rate is more than 100, we call that as a tachycardia. And when rate is less than 60, we call that as a bradycardia. But we cannot label that whether it is a sinus, whether it is nodal, whether it is atrial, whether it is ventricular. You cannot say by examining rhythm, by examining pulse. Yes, by examining pulse, you can find out whether it is regular or whether it is irregular. And if it is irregular, it is regularly regular or irregularly regular. That can be easily examined by examining pulse. But when you examine the ECG, then you can examine one more thing. So here you will be able to identify rate, whether normal, tachy, brady, whether it is regular, irregular, whether it is occasional, regularly irregular, or irregularly irregular. And most important part, you will be able to find out the pacemaker origin, whether it is from SA node, so we call it as a sinus rhythm, atrial rhythm, junctional rhythm, or we call nodal rhythm, ventricular rhythm, and pacemaker rhythm. This you can identify only if you examine rhythm strip properly. Now say this is one simple example where you can see a rhythm strip. In this strip you can see that there is a P wave followed by QRS complex. All QRS complex are identical. All QRS complex are narrow. All QRS complex are preceded by P wave. P wave is upright. QRS complex and T wave is upright. So this is classical sinus rhythm. This is typical sinus rhythm, very easily. So now to find out what is a rhythm, one, you have to calculate the rate. And when you calculate the rate, you can mention whether it is a normal, tachy, or brady. But when you want to find out the pacemaker rhythm, you have to examine one, regularity. So while calculating the rate also, regularity helps you. So if it is regular, we usually use the formula 1500 divided by number of small square or 300 divided by number of big square. Or if it is irregular, then 6-second strip, number of QRS complex multiplied by 10 or number of P wave multiplied by 10. So that will help you to calculate your rate. When you want to find out the pacemaker rhythm, you will have to at least answer few of the things, whether there is a P wave or not, and if P wave is there, it is normal or abnormal. What about PR interval? It is normal or abnormal. And QRS complex, whether it is normal or it is white. All this answer, if they are given, then only you will be able to answer what type of rhythm it is. Hence, now we'll proceed in a systematic pattern. So first, always, whenever you look at the rhythm strip, first find out RR interval, whether it is regular or irregular. And if it is irregular, it is occasional, or it is regularly irregular, or it is irregularly irregular. Then try to find out the rate by any method. If it is regular, what is the technique that we have already explained you? That if it is regular, you can calculate 1500 divided by number of small square or 300 divided by number of big boxes. And if it is irregular, then 6-second strip, number of QRS complex or number of P wave multiplied by 10. So that is how you can identify. Then look for P wave, look for QRS complex, look for T wave, and measure your interval, particularly PR interval, QT interval, and QRS complex. Look, QRS complex is broad or narrow, and P wave is related to QRS complex or not. After looking at all these things, then only you can say that the pacemaker origin. Now we are going to regularity. Pulse wise, you can find out that it is regular, but ECG wise, it may be regular, but rhythm, as far as pacemaker is concerned, it can be abnormal. We'll be going through some of the ECG and you will understand that particular part. So look at the RR interval. And if RR interval is regular, we call that this is a regular rhythm. But origin of pacemaker wise, it can be sinus, it can be atrial, it can be nodal, it can be ventricular, it can be pacemaker. And as far as irregular rhythm is concerned, it can be occasional irregularity, regularly irregular, and irregularly irregular. We'll be going through one by one. So now I'll be showing you some of the ECGs. So regular rhythm can be sinus, what we call is a normal sinus rhythm, but still in that regularity it can be bradycardia, it can be tachycardia, or it can be sinus arrhythmias. And as far as the abnormal origin of pacemaker is concerned, it can be nodal, it can be ventricular, it can be pacemaker, or it can be even atrial. And rhythm may be still, as far as regularity concerned, can be regular. So you can see now some of those ECG. This ECG shows RR interval is constant, PP interval is constant, P wave is preceded before QRS complex, PR interval is constant, ventricular rate is between 60 to 100 per minute, QRS complex is normal, that is less than 1.12 second, and PR interval is between 0.12 to 2.2 second. And rhythm is between 60 to 100, so we'll call this as a normal sinus rhythm. So this is a normal ECG rhythm strip. And you can see one lead which is a limb lead and one lead which is a chest lead. Now this shows that the rate RR interval is more, so rate is less than 60. All other criteria are fulfilled, that the P wave is preceded before a QRS complex, QRS complex is narrow, PR interval is constant, T wave is upright. Hence, this is a sinus rhythm, but rate wise it is bradycardia, so we call that as a sinus bradycardia. Now you can see here, in this ECG, rate wise, this is tachycardia. All QRS complex is preceded by P wave. QRS complex is narrow. P wave is upright. PR interval is constant. But if you see in this ECG, there is an ST elevation in lead 1, AVL, V1, V2, V3, V4. Also slight elevation in V5. This is an anteroseptal infarct, anterior wall with septal wall infarct. But as far as rhythm is concerned, it is a sinus rhythm and there is a tachycardia. So this is classical sinus tachycardia with, you can see that there is associated changes which is suggestive of an anterior wall infarct. and there is a reciprocal change in lead 2, lead 3 and AVF. This is called reciprocal changes. So this is that particular ECG. Now you can see here the RR interval is constant and there is a bradycardia. But if you see PP, this P, there is a second P here, there is a third P here, there is one more P here, one more P here. So this P wave, if you see these two P wave, this PR interval, this PR interval, this PR interval is constant. And this is a broad QRS complex. So this is a ventricular complex. And there are two P wave and one complex following this P wave. So this is 2:1 block. And this is a ventricular premature. This is a ventricular complex. So we can say that there is no relation of QRS complex to P wave. Either this is a complete heart block or this can be 2:1 AV block with conduction, intraventricular conduction defect. So this you will be able to differentiate by doing an EP study. But by and large, if you look at this ECG, this will go more in favor of a complete heart block because P wave rate is faster than ventricular rate, QRS complex is broad, PP interval is less than RR interval, hence this will be more in favor of a complete heart block rather than 2:1 block with aberrant conduction. So this is 2:1 block with aberrant conduction. Now you can see here, this is a classical ECG which shows a complete heart block where you can see this P wave, there is another P wave here, there is another P wave here, this is the P wave, there is one P wave here, one P wave here. This P wave is not related to QRS complex. QRS complex is broad, ventricular rate is very slow, atrial rate is faster, and P wave is not related to QRS complex. Hence, this is a classical complete heart block. But rate wise, if you calculate the ventricular rate, it is slow. Or we can call idioventricular rhythm with a slow ventricular rate. And atrial rate is close to normal. We can say that between these two, approximately nearly 13 small square. So 1500 divided by 30, almost it will come to, say it is coming to almost 13 small square. So it is more than 100. So there is atrial rate is faster than 100. So this is atrial rate is faster than the ventricular rate. This is classical complete heart block. Now you can see here, this ECG does not show any P wave. So as it does not show any P wave, definitely this is not what we call as sinus rhythm. This is not sinus rhythm. So either this is nodal or this is ventricular. Now if you see RR interval is absolutely constant. RR interval is constant. And here it seems that there is a P wave here, there is a P wave here, there is a P wave here, but it is not related to, you can see here, but it is not related to QRS complex. And this rate is called idioventricular rhythm because it is less than 60. It is less than 60. But when we calculate the exact rate, so this is one big square, second, third, so it is again around 50. So the rate is around 100. So if we say the rate, ventricular rate is 100, so this will become tachycardia. But if this is approximately, if we calculate, this is around 16 small square, so it is less than 100. So when it is more than 40 but less than 100, we call that as accelerated idioventricular rhythm. So this is accelerated idioventricular rhythm. But regularity wise, it is regular. Now we are going to an irregular rhythm way. Occasional irregularity, regularly irregular, and irregularly irregular. So I'll show you some example. Occasional irregular are usually commonly because of the premature beats. Occasional premature beats. Maybe supraventricular premature beat, which can be atrial, can be nodal, or ventricular premature beat. And sometimes because of escape rhythms. These are the three classical examples where you will get occasionally irregularity. Now the importance of this is, we'll show you in a further slide, that whenever you get an escape, but if this escape or what we call as an arrest followed by a beat, because there is no P wave, there is no QRS complex, the person will not have a apex, person will not have a pulse. Hence, there will be no apex pulse deficit. While in case of atrial premature beat or a supraventricular premature beat, I am explaining simultaneously that because the conduction from an atrium via AV node, it goes to the ventricle in a normal pattern, ventricular systole will take place. You will have a cardiac output little less than normal. So pulse will be there of a little less volume, followed by a pause. But second beat, which comes as a normal beat, will have a good volume and it will be with a large volume pulse. This is very, very typical. So apex will be there, pulse will be also there for each atrial premature beat. So apex will be there, pulse will be also there. So there is no apex pulse deficit. But whenever there is a supraventricular premature beat or a atrial premature beat, pulse will be of little low volume. Following pulse will be after pause and it will be with a good volume. While in a ventricular premature beat, ventricular beat is premature and it comes during diastole of ventricle. So during a diastole, ventricle is supposed to fill up, but ventricle doesn't get a chance to fill up completely. There is no atrial kick. There is no P wave before a QRS complex. Hence, there is no filling of ventricle because of atrium. So ventricle is having a minimum quantity of blood, and whenever it contracts, apex will be produced. There will be hardly any cardiac output, hence pulse will not be palpable, and this will produce apex pulse deficit. And this is a characteristic of a ventricular premature beat, which you can identify while examining a pulse. So if you get a deficit in a pulse compared to apex, this is due to ventricular premature beat. And this, if they are occasional ventricular premature beat, it will give rise to occasional irregularities. And this is, now we'll be showing you in an ECG how does it look like. I will explain to you a physiology side of it. So these premature beats are also called premature beats, premature contractions, premature systole, premature depolarization, extrasystole, ectopic beats, and depending upon the pacemaker, we call sinus, and then we use this terminology, or we call atrial beat, atrial premature beat, atrial premature contraction, atrial premature systole, atrial ectopic beat, nodal ectopic beats, ventricular ectopic beats, ventricular extrasystole, atrial extrasystole, etc. These are the different. But the most common word which are being utilized is premature atrial contraction or atrial premature beat, premature ventricular contraction or ventricular premature beats. These are the common. Or sometimes they use a ectopic beats as a terminology. But common utilized is premature beats. These are the common. And this is in ECG how will you differentiate between the three groups: atrial extrasystole, nodal extrasystole, and ventricular extrasystole. For this, ideally you should know how is the rhythm identified on a rhythm strip. For an atria, there should be a P wave. But whenever there is an extrasystole, that extrasystole will be with an abnormal P wave. It will be followed by a normal QRS complex. So QRS complex will be normal, but will be preceded by a P wave which is abnormal. Maybe of an abnormal shape, maybe inverted, maybe biphasic, maybe abnormal as far as amplitude is concerned, etc. But it will be little early. So we call that as a premature. And that QRS complex is followed by a pause, which is usually we call as a no compensatory pause. So it is not exactly the compensatory pause. It is little less than that. So we always use the word non-compensatory pause. While in case of a nodal, because it is coming from a AV node, usually P wave is absent, or P wave may be just before QRS complex, because if it is very close to AV node, then P wave may be present, but it will be just before QRS complex, because QRS complex will start when the impulse travel after the bundle of his and it activates the septum. So if it is from a higher level, then you will have a presence of a P wave because it will activate the ventricle. But P wave will be abnormal. It will be usually inverted. If atrium is activated after activation of bundle of his and bundles, then you will get a P wave after QRS complex. QRS complex will be of a normal shape. We call as a narrow shape. And there will be followed by a little pause. But again, this will be incomplete pause. This is the way to differentiate a nodal extrasystole. Now, difference between these two, that is atrial and nodal, is the P wave is just before QRS complex, while in case of an atrial, the P wave is followed after a normal QRS complex, and there is a short PR interval. There is a PR interval which is being present. So that is a way you try to differentiate between these two. While in a case of a ventricular extrasystole, P wave is always absent before a QRS complex. So there is no P wave before that QRS complex. QRS complex is premature. It is broad. T wave is in opposite direction of a QRS complex. So if QRS complex is upright, T wave is inverted. If QRS complex is inverted, T wave is upright. And it is followed by a full compensatory pause. These are the three extrasystole which you will see in an ECG rhythm strip. And you should be able to differentiate atrial extrasystole from junctional from ventricular. So these are the three classical example of an extrasystole, or we call it an ectopic beat. Now here you can see that this is P wave followed by QRS complex, P wave followed by a QRS complex, P wave followed by a QRS complex. This is also a P wave followed by a QRS complex. But if you see this RR interval, see this RR interval. Now this RR interval is different. So rhythm wise it is irregular, but this is occasional irregularity. Again, if you see this RR interval is constant and this is same. So now this has come early. There is a P wave. This P wave and this P wave is different. And then this QRS complex and this QRS complex is identical. So this focus has come from the atrium. That's why it is called as atrial. And as it has come premature, we call it as a premature. So it is a premature atrial systole which will produce P wave followed by PR and followed by a normal QRS complex. And you see this RR interval. This is more than the previous RR interval. Hence, there is a compensatory pause. But this compensatory pause is not complete. That's why it is called as a non-compensatory pause. And this is classical example of atrial premature beat or premature atrial contraction. And this is single. So this is occasional irregularity. Again, you can see here similar thing, but here the P wave is followed by a QRS complex which is little broad. This will happen because when the P wave stimulates the bundle of his, while passing through that, it takes an aberrant pathway and it then activates the QRS ventricle to produce a broad QRS complex. So this is atrial premature beat with aberrant conduction. That's the reason why the QRS complex is broad. But this is the atrial premature beat. That is the only difference between the previous one. You can see this previous one. This is narrow QRS complex and this is a broad QRS complex. But all other criteria are same. And because all other criteria are same, This is because of the aberrant conduction in the conducting system. Now here you can see that these are the QRS complex, RR interval is constant, and here it is an irregular. This QRS complex is broad and there is no P wave in front. You can see here there is no P wave in front. Here also there is no P wave. There is no P wave. So there is no P wave. So it is not coming from sinus node. And this is a broad QRS complex. So this is a ventricular complex. And followed by a negative T wave. So this is ventricular premature beat. And this QRS complex is coming early because if you take this RR interval, it should come somewhere here. So this has come little early. So this is premature. So this is a premature ventricular beat or ventricular premature beat. And there is a followed by a pause. And this pause is a complete compensatory pause. That's why this is called as a complete compensatory pause. We'll be explaining you that in another lecture we call it an extrasystole lecture. So we'll explain you the what is compensatory pause, etc. So this is regularly occasional irregularity, and this particular two QRS complex are identical. So they are coming from the same focus. That's why it is called unifocal premature beat. This is that particular diagram to explain you that the compensatory pause is full and compensatory pause is incomplete. Now you can see here, this is a normal sinus rhythm. This is RR interval and this is RR interval. Both are same. Now if you see when you get a ventricular premature beat, this is a normal QRS complex, that is normal sinus beat. Then you got this premature. This is followed by a pause and you are getting a second beat which is coming at the identical time, which is expected time. So this is a complete compensatory pause. While this is a normal sinus beat, this is a premature beat which is because of an atrial contraction, and then it is followed by a pause, but it is coming early before expected. This is the expected time of second beat because this is supposed to be first, second and third beat. This is first, second and third beat has come after a full compensatory pause. This is first beat, this is second beat, this is premature beat, this is a premature beat. This has come early, so this is premature, this is also premature. But after this compensatory pause is not complete. This should have come here. Instead of that, this has come early. So this is a non-compensatory pause. So in a case of an atrial premature beat, you will have a non-compensatory pause. In a case of a ventricular premature beat, you will have a full compensatory pause. So keep this thing in mind. So this is an atrial premature beat. This is a ventricular premature beat. Now you can see here, this is RR interval. See this RR interval. This is very big. Again, this is an RR interval. This RR interval and this RR interval, they are same. But this is irregular. Now if you see here, there is no P wave, no QRS complex. Means sinus node has not discharged any electrical impulse. And there is a beat gap. So we call sinus arrest or we call sinus pause. This is very, very typical because of the sinus node disorders. And if this becomes very much prolonged, then this can give rise to a person can become unconscious and can be dangerous, and person can even have sudden cardiac death. So do remember, usually the sinus arrests are for a short period and person will have a little dizziness. If it is little long, person can have a syncope, and if it is very much prolonged, person can go into what we call as a cardiac arrest or sudden cardiac death. Hence, whenever you see such strip between two RR, if it is markedly prolonged and there is no QRS complex, it is either a sinus pause or we call sinus arrest, or there is another terminology we call as a sinoatrial exit block, because sinus node discharge an impulse but does not come out and activates the atrium and activates the ventricle. But this two, that is difference between sinus arrest and assay block you can identify by doing a good EP study. So that will be the way you can identify. So a simple way to identify the sinus arrest is, now before each QRS complex you can see there is a P wave. So there is a P wave. Now there is a pause, but after that pause again you have got a normal PP interval, normal RR interval. So that's why this is more in favor of a sinus arrest rather than a sinoatrial block. Now here you can see there is a broad QRS complex, and before that there is a small spike. Here there are two spikes. So this is dual spacing. This is atrial pacing, this is ventricular pacing, and there is a spike, and after that there are no QRS complex, meaning that pacemaker has given output, but there is no generation of electrical activity in the atrium or a ventricle. So this is called a failure of output, and this will happen in a case of whenever a pacemaker fails to do its normal activity, or there is a break in the wire, etc. It will give rise to this particular phenomena, and this will again produce occasional irregularity. Occasional irregularity. Now you can see here in this ECG. Now this is a P wave followed by a QRS complex, P wave followed by a QRS complex. Here you will have a better outlook. P wave, QRS complex, P wave, QRS complex. There is a P wave. So SA node has given a discharge. It has gone to atrium, but it is not transmitted. So it is non-conducted, premature atrial contraction. So atrium is contracted, it has come premature, but this P wave is not transmitted to ventricle. So you don't have a QRS complex. As you don't have a QRS complex, you don't have a pulse. You don't have a apex. And this is very typical in a non-conducted atrial premature beat, or we call it the atrial premature contraction. So there is only atrial contraction, there is no ventricular contraction, and this will again produce, this is not very common, so this will be again occasional irregularity. These are rare ECGs. Here again you can see a similar way. There is a premature beat and there is an aberrant conduction. I have already shown you before this. So this is in an occasional irregularity. This I have shown you, occasional irregularity. This is a ventricular premature beat. This is a ventricular premature beat. Now you can see the difference between this beat and this beat. This is upright, this is inverted. So this is coming from one focus, this is coming from another focus. That's why it is called multifocal ventricular premature beat. So these are of different shape. You can see here also, this is different shape, this is different shape. So this is multifocal ventricular premature beat. We'll be doing in detail in a chapter when we are doing regarding a ventricular rhythm and ventricular arrhythmias. Now you can see this is P wave QRS complex, P wave QRS complex, P wave QRS complex. These are sinus beats, and followed by a broad QRS complex, no P wave before, broad QRS complex, no P wave before. So these are two VP beats coming in succession. So this is called couplets or coupled premature beats, and they are ventricular complex, so it is called ventricular premature beat couplets. So again this will produce occasional irregularity. During this time you will have no pulse. So this will be missed beats. Now we come to regularly irregular. We have finished that. So now we are going to have a premature beat which is regularly irregular. Now you can see here, this is a P wave, normal QRS complex. This has come little early. Again this is a P wave followed by a QRS complex. There is a little pause. Again P wave QRS complex, premature beat. So these are atrial premature beats, because this shape is different. You can see all this P wave shape are same. This P wave shapes are same. This is same shape. But if you look at this, these shapes are different. So these are atrial premature beat. Alternate beat is a atrial premature beat. So this is called atrial bigeminy. So normal beat, premature beat. Normal beat, premature beat. Normal beat, premature beat. This is sinus. This is atrial premature beat. That's why this is called atrial bigeminy. Means normal sinus beat is followed by a atrial premature beat. And it will be regularly irregular. Again, you can see here, this is a normal sinus beat, P wave, normal QRS complex, P wave, normal QRS complex, but it is followed by a broad QRS complex which is premature and compensatory pause. So alternate beat is a ventricular premature beat. So sinus beat followed by a ventricular premature beat means pulse and you will have a deficit. Pulse, you will have a deficit. Pulse, you will have a deficit. So this will be regularly irregular. But during this time, you will have apex. So this will show you apex, but there will be no pulse. Hence, this will give you a apex pulse deficit. While in this, you will have a pulse, you will have a pulse. And this pulse will be with a low volume. This pulse will be with a little good volume. So this will be alternate pulse will be with a good volume, low volume. But you will have a pulse. So there will be no apex pulse deficit in an atrial rhythm, atrial premature beats. So this is atrial bigeminy. This is ventricular bigeminy. This is trigeminy. Every third beat is a ventricular premature beat. 1, 2, and 3. 1, 2, and 3. So every third beat is a miss beat. So this will again give rise to apex pulse deficit. This is every fourth beat is a ventricular premature beat. So we call ventricular quadrigeminy or tetrageminy. So every fourth beat is a ventricular premature beat which will give rise to pulse deficit. So there will be apex pulse deficit. These three will have a pulse. Here there will be no pulse. This is pentageminy. Every fifth beat is a ventricular premature beat. So we will have a 4 normal regular pulse followed by a gap. We call as a pulse deficit. So you will have an apex pulse deficit which you can identify while taking pulse and comparing with apex. So you can find out apex pulse deficit. And here you can see this is an abnormal broad QRS complex not preceded by P wave, T wave in opposite direction and full compensatory pause. This is a characteristic of a ventricular premature beat. And this will give rise to regularly irregular. Now we go to irregularly irregular. And this will be produced in one classical example we call as atrial fibrillation. But in a case of an atrial flutter, if there is a variable block, it will also produce irregularly irregular pulse. So these are the two classical examples which will produce irregularly irregular rhythm. Once in a while, if there is a multiple premature beats at a irregular time, we call as a irregular coupling time, then you can have a irregularly irregular pulse, and also on an ECG rhythm strip, you can find out irregularly irregular QRS complexes. So this is an example of, you can see RR interval. It is constantly changing. It is constantly changing. It is not regular. And in an isoelectric line, you can hardly see any P wave complexes. Here you can see little zigzag line. These are called fibrillatory waves, or we call as a F wave. F wave. So this is classical example of atrial fibrillation. And while calculating the ventricular rate, we will have to utilize 6-second strip. Calculate the number of, this is approximately 6-second strip. Calculate the number of QRS complex. These are 7. 7 multiplied by 10 is 70. So the rate is 70 as far as the ventricular rate is concerned. And atrial you cannot calculate because you don't have any P wave at all. So this is classical example of atrial fibrillation which will produce irregularly irregular pulse. On a pulse examination as well as on an ECG strips, you will say that this is irregularly irregular rhythm. Again, you can see here. Here you can see a sawtooth type of a P wave. This is typical of a atrial flutter. And if you calculate the rate, this is approximately comes out to be around 300. So atrial rate is 300. Ventricular rate, if you calculate the RR interval, it is not constant. So this is a variable block. And this is a 6-second strip. So if you calculate, atrial rate is approximately around 300, and ventricular rate, if you calculate 9 multiplied by 10, so it is 90. So ventricular rate is around 90. Nutan, hello, ઘરે છું, okay, So atrial rate is fast, ventricular rate is slow, and ventricular rate is irregularly irregular, and this is an example of atrial flutter with variable block, because P wave is a sawtooth appearance, that's why this is atrial flutter. So this is atrial flutter with a variable block which will be irregularly irregular. Again, you can see here, when you get a premature bits, this is a ventricular ectopic bit, this is single bit followed by a couplets, again single bit, here there is a triplets, again a single bit. So this will produce irregularly irregular pulse, because these ectopic bits are coming irregularly, and they are coming at an irregular interval, and their number of bits are also irregular. So this will also produce irregularly irregular pulse. One of the example, this is single bit, this is couplets, this is again a single bit, this is triplets, again a single bit, and they are coming with a different coupling intervals, and that's why this will be irregularly irregular. Again similar example, you can see this is almost ventricular bigeminy, followed by, here you have got a 3 ventricular premature bit, we call as a ventricular triplets, and then there is again a ventricular couplets, and this is again a single ventricular premature bit. So this is irregularly irregular. Now we are going to what we call as a rhythm by an ECG strip. So we call as a, we always look at the rhythm strip. Usually lead 2 is taken as a rhythm strip, or you will have a chest lead, one of the chest lead, commonly it is V1 or V2, which is taken as a rhythm strip. But by and large, lead 2 is the most common strip which is being taken, and at least it should be more than 6-second strip. And when you examine that rhythm strip, you should be able to make out whether it is a sinus rhythm, atrial rhythm, AV nodal rhythm, or we call it a junctional rhythm, ventricular rhythm, or pacemaker rhythm. You should be able to identify. And for identifying that, you should answer some of the question. P wave is present or not? RR interval is regular or irregular? And if it is irregular, regularly irregular or irregularly irregular? Does P wave precedes every QRS complex? What is the PR interval? It is normal, short, or prolonged? What is the QRS complex, narrow or wide? Is there any pacemaker spike? And then calculate the rate. When you put all this together, you can put what is the origin of the rhythm. So now, these are the answers which we have given. If P wave is present, it may be sinus, it may be atrial, it may be AV nodal. But if there is no P wave, it can be ventricular rhythm, atrial fibrillation, idioventricular rhythm. And also you can see sometime in a nodal rhythm, or we call it a junctional rhythm. But if you say that P wave is present, yes, it is sinus or atrial. If it is inverted, shape of the P wave is does not like other normal P wave. So it is either a left atrial ectopic rhythm or atrial premature bit, or we can call multifocal atrial bits. If P wave is like sawtooth appearance, then we call that as atrial flutter, and this is very typical. So by looking at the P wave presence and the shape, you can identify these different characteristics of the rhythm strips. Then do P wave occur at a regular rate? If answer is yes, more in favor of sinus, atrial, junctional, or complete heart block. If answer is no, it is in favor of a ventricular rhythm. Usually in a ventricular rhythm, P wave are not present, so we cannot identify. It can happen in a nodal because P wave are absent. So you cannot again identify whether it is regular or irregular. In atrial fibrillation also there are no P wave. And in idioventricular rhythm also there are no P wave. So we cannot identify whether the P wave rate is regular or not. Is there P wave for each QRS complex? If answer is yes, sinus, paroxysmal atrial tachycardia, multifocal atrial tachycardia, left atrial ectopic rhythm or nodal rhythm. If answer is no, it is in favor of atrial flutter, atrial fibrillation, complete heart block, Mobis type 1 and Mobis type 2. Because in this condition, particularly complete heart block, Mobis type 1, Mobis type 2, P wave rate is faster than ventricular rate. If look at the PR interval, if PR interval is abnormal, it is very commonly in a AV block. It may be first degree, second degree or complete heart block. Look at the QRS complex. QRS complex, it is wide, it is a ventricular complex. If QRS complex is narrow, it is sinus or atrial or nodal. And if you see a pacemaker spike before a QRS complex, we call it a pacemaker complex. And depending upon the spike, whether it is an atrial pacing or it is a ventricular pacing or it is a dual pacing or we call it a AV pacing or we call sequential pacing. So rhythm wise, this will be the way we try to identify.